presentation by our yes, sir. Over to you now. So our PGs, senior PGs, Dr. Neha and Panchami will be presenting a case of thyroid swelling. Let's start.
Good evening, everyone. Thank you for giving me the opportunity to present the case on thyroid swelling. 35-year-old female patient hailing from Hoskote, housewife by occupation, came with the chief complaints of swelling in front of the neck since 2 years, palpitations since 1.5 years, and weight loss since 6 months. History of presenting illness. Patient was apparently normal 2 years back. Then she noticed a swelling in front of her neck, more towards the right of the midline, which was insidious in onset and gradually progressive. Initially started as 1 into 1 centimeter swelling, which progressed to around 10 into 6 centimeter, involving both sides of the midline over a period of 2 years. It was associated with dull aching pain of moderate intensity and intermittent in nature, non-radiating, no aggravating or relieving factors present. Patient also complains of palpitations from past 1.5 years, for which she was started on medications. She also gives history of weight loss of around 20 kg over a period of 6 months, despite of having good appetite. Patient complains of excessive sweating, heat intolerance, diarrhea, and history of menorrhagia from past 1 year. Patient complains of dysphagia to solids more than liquids, dyspnea on exertion, and hoarseness of voice. Patient has been evaluated and treated at local hospital and has been started on medications. No history of any other swellings in the neck, no history of syncope, tremors, diplopia, no history of constipation, amenorrhea, or cold intolerance, no history of bone pain, hemoptysis, and jaundice. Coming to past history, patient is not a known case of diabetes mellitus, hypertension, ischemic heart disease, and tuberculosis. No history of previous surgeries in the past. Treatment history, patient was on tablet carbimazole 10 mg twice a day for 2 years and tablet propranolol 10 mg once a day for 20 days. Personal history, diet, patient consumes non-vegetarian diet, appetite was increased, sleep disturbed due to palpitations, bowel habits were disturbed, diarrhea was present, bladder normal and regular, menstrual history, menorrhagia since 1 year, family history, there was no history of similar complaints in the family. Coming to physical examination, Dr. Panchami will be telling further about it.
Coming to the general physical examination, patient is a moderately built, nourished female patient, conscious, cooperative, well-oriented to time, place, and person. The pulse rate was 89 beats per minute, right radial, with regular rhythm and good volume. BP is 112 by 80 mmHg on the right brachial artery in sitting position. The respiratory rate is 16 cycles per minute, thoracoabdominal. Patient had pallor, icterus sinuses, clubbing, lymphadenopathy, and edema were absent. Coming to the local examination, with due consent and adequate exposure, patient has been examined in sitting position in the presence of a female attendant. This picture shows the front view of the thyroid swelling, and this is from the right and left side. Coming to inspection, there's a swelling in the region of the thyroid gland measuring about 10 into 6 centimeters in the midline, extending to both the medial border of sternocleidomastoid muscle, horizontally measuring up to 10 centimeters, and the upper and lower border are about 8 and 2 centimeters from the suprasternal notch. The swelling is butterfly shaped. The surface of the swelling appears nodular. Upper and lower margins are well made out. Lateral borders are ill-defined.
1 minute. Can you hold on? Go back to that picture, please. Front picture. Dr. Panchami, can you describe the swelling looking at this picture? It will be better for people who are joined in.
So on inspection, the swelling is a butterfly-shaped swelling. The skin over the swelling appears normal. The upper and lower borders of the swellings are well made out. The lateral borders are ill-defined. The skin over the swelling appears normal. The swelling moves on deglutition. There is no dilated veins or scars over the swelling. There are no other visible swellings in the neck other than the thyroid swelling.
Okay. Proceed, please.
On palpation, there is no local rise of temperature and the swelling was non-tender. The swelling moves upwards with deglutition. Both the lobes and isthmus were enlarged and were palpable. The surface of the swelling is nodular and firm in consistency. The swelling measures 10 into 6 centimeters. Isthmus measures 2 into 4 centimeters. The right lobe measures 6 centimeters from the midline to the sternocleidomastoid, and the left lobe 4 centimeters from the midline to the sternocleidomastoid. The lower border of the swelling is palpable. The plane of the swelling is deep to deep fascia. Trachea central in position. Cocker's test is negative. Bilateral carotid pulses were well felt. That is, Berry sign was negative. There was no palpable thrill, and cervical lymph nodes were not palpable. The examination for signs of thyrotoxicosis, there was no of exophthalmosis, chemosis, eye signs, tremors, and orthopnea. Examination for signs of metastasis, there were no bony swellings over the skull, spine, or other long bones. There were no cervical lymph nodes present. Systemic examination, CVS, RS, and per abdomen were all normal. CNS, a patient was conscious, well oriented with GCS 15/50. Provisional diagnosis, this is a case of multinodular goiter in secondary thyrotoxicosis.
Good. Can you summarize the history? This, mind you, the PGs need not be doing it in the exam, but for the people, those of us who have joined in late, can you summarize the history so far?
So, we have a 35-year-old female patient who came with complaints of swelling in front of the neck since 2 years, with palpitations from 1.5 years and loss of weight in 6 months. And the patient also has complaints of pressure symptoms and symptoms of hyperthyroidism. And the swelling is around 10 into 6 centimeters.
What were the standout symptoms of hyperthyroidism that you observed in this patient?
So the patient had weight loss of around 20 kgs over a period of 6 months. It was an unintended weight loss. Patient had palpitation, sweating, and heat intolerance.
Yes, okay, then. Yeah, just summary, yeah.
So on examination, the patient had a butterfly-shaped swelling.
No, the important thing is she was treated elsewhere.
Yes, sir.
So in thyroid, whoever is tuned in, it's important to ask the patient whether she underwent any treatment for the same, because the 2 years history, you must ask the patient whether she underwent any treatment elsewhere. And that treatment becomes important to us because the thyroid can get varied because of that. So functionally and in its anatomical structure also, it can get varied. Suppose she has a regular treatment or an irregular treatment. Was she having a regular treatment in those 1.5 years?
Yes, sir. From the past 2 years, patient was on tablet carbimazole 3 times a day. And from the past 20 days, she was started on tablet propranolol.
Okay, okay. Obviously, it is one of our good colleague who has started the treatment. So did she have a proper compliance of the treatment?
Yes, sir. She was compliant with the treatment.
No stopping any time, 2.5 years?
No, sir. She was compliant. And she was advised for surgery also after achieving the thyroid.
Okay. Where was this? Which hospital was this?
So it is in a government hospital in Kolar.
Kolar, okay. So she did not get operated, is it?
No, sir. She was asked to continue on medications for some more time.
Okay, that's what the patients usually tell. They suppress the fact she might have been advised surgery, suppress that. Okay, right. On examination, what's the summary, please?
There is a 10/6 centimeter swelling in the region of the thyroid gland, which moves with deglutition. The swelling was non-tender.
Why is that? Moves with deglutition, moves with deglutition. We need to hear that. Why do you need to tell that as a student, whether UG or a PG?
So the swelling, the thyroid gland is fixed to the trachea. With the help of the Berry's ligament.
No, I'm not asking how. Why that sign is important to us.
So to confirm that it is a thyroid swelling.
Yes, a swelling in the region of the thyroid that moves with deglutition is often a thyroid swelling. So in the exam, what happens at the PGs, UG or PG level, they forget to tell the sign, and then the examiner ends up asking what else, you all become tense. So lest you forget, as soon as you start swelling, examination of the swelling inspection itself, you must tell that it means deglutition. Yes, okay. So and therefore it's a thyroid gland, and you ask, proceed examining and concluding about it.
Yes.
Yeah, then what else? Anything else? Any signs that you saw during palpation that you can tell?
So sorry, sir.
Any other sign that you look for in particular in the neck and the thyroid gland you are supposed to see?
So since it's a long-standing thyroid, we have to look for tracheal compression. We should do the Cockers test for tracheal compression, which was negative in this patient.
Okay. Long standing again. Did look for Berry's sign? What is that Berry's sign?
Berry sign is positive when there is when the carotid pulsations are not felt. It happens in this long-standing thyroid where there is lateral extension and the pulses are shifted posteriorly or they're absent.
No. The correction is the right answer would be
Encasement of carotid sheath.
classic local sign of a malignancy. So that's why you look for it. So it is not infiltration of the carotid, it is encasement. That should be your direct answer. Yes, anything else? In palpation? Any thrill that you look for?
There was no palpable thrill on palpation.
Thrill is always a palpative finding, so you do not say palpable thrill. Okay, so where do you look for thrill in the case of a thyroid gland?
In the superior pole of the thyroid.
Yeah. Can you tell us why?
The superior thyroid artery enters the gland from the superior pole. And it is more superficial. And it is superficial. And
The most straight, larger blood supply of the thyroid gland is through the superior thyroid artery. And therefore, when there's a hypervascularity in the gland, initially it will start to show up in that place. Though the inferior thyroid artery may be lower down, if there'll be thrill everywhere, including over the gland. So initially you will pick it up in the superior pole.
yes.
Okay. Right. Then what else you look for in locally? You have seen. Did you look for lymph nodes?
Yes, sir. There was
Which
no
group of
palpable.
lymph nodes get affected first, please?
So the sixth group of lymph nodes.
Central compartment. Okay. So what's your provisional diagnosis?
So this is a case of toxic multinodular goiter in hyperthyroidism.
So toxic multinodular goiter with hyperthyroidism. No. If here this patient who's been on carbimazole,
Yes.
so when you palpated, I think the pulse rate was 82 or something.
Yes, sir.
Whether it is a primary or a secondary thyrotoxicosis, the diagnosis rests on the history, whether the symptoms and the swelling started together,
Yes, sir.
or if at all the symptoms first and then the swelling later. That is the classic history of thyrotoxicosis, where you use that term for Graves' disease, primary thyrotoxicosis. So history is very important. Here, it's as you said, long-standing goiter, and then 1.5 years or so, she started having symptoms. So and therefore, it could be a multinodular goiter because the clinical findings, the surface of the gland is multinodular, and therefore it could be a multinodular goiter. In which case, the hyperthyroidism is secondary to the long-standing multinodular goiter. That should be a right answer. But your final complete answer should be multinodular goiter with secondary hyperthyroidism, not thyrotoxicosis,
Yes.
under control because she's on treatment and your pulse rate seems to be normal and all the signs of toxicity have disappeared now. So the proper diagnosis as a postgraduate student one should tell is multinodular goiter with secondary hyperthyroidism under control. That should be the complete diagnosis.
Yes.
Sir, anybody else, sir? Please can go ahead and ask. Any questions from anybody else? But how will you manage this case?
First, I would start investigating the patient. We would send all the routine blood investigations for the patient. Complete blood count, RFT, electrolytes. And we start with a thyroid function test to assess the physiological status of the thyroid. And then we'll go for an ultrasound of the thyroid gland, followed by an FNEC of the gland.
What do you expect in thyroid function tests? If you're allowed to do one test, which one will you do? A patient who comes into the OPD.
So TSH.
Starting point. If the TSH is normal, you can stop investigating that stage itself. What do you expect in a patient? Suppose he's not on treatment. Can you hear me? The internet is a little problem.
Yes, sir.
Yeah, please. What do you expect the TSH to be in a florid hyperthyroidism case?
TSH will be very low.
It will be, yes, low. So what's the relationship between thyroxine and TSH? What do you call that? What's the relationship between TSH and thyroxine called? What type of relationship they have?
It will be a negative feedback mechanism.
Mechanism. Okay, so that's why if the TSH is low, that means to say that thyroxine T3, T4 must be high. Okay,
Yes.
that could be a finding here, right? Any other investigations you want to do? What do you want to do, an ultrasound?
So we'll do an ultrasound to find out the nodular or cystic status of the swelling, and
For the sign, look for the malignancy if present in the swelling or not, sir, by seeing the swelling is solid or cystic, if it is more taller or wider, and multinodularity, involvement of
Malignancy can this be?
Yes, sir.
If you develop malignancy, what type of malignancy it will be? Long-standing multinodular
The
goiter.
follicular carcinoma, sir.
What's the incidence? Hello, can you hear me?
Yes,
yes,
sir.
sir.
Yeah, what's the incidence?
10%.
10%.
About 10 to 15%. Yeah. So in your examinations for the PGs, there are some of the examiners who come from Tamil Nadu. In the clinical examination itself, they want you to comment whether it is malignant or non-malignant based on the clinical findings. So you can say non-malignant based on the clinical findings. Okay. Any other investigations?
FNAC, sir.
Okay, that's been done. So if your diagnosis comes out as a multinodular goiter with secondary hyperthyroidism, how will you treat this patient?
The patient has to be started on antithyroid medications until she
The
has
diagnosis is listen to my words, the diagnosis is multinodular goiter with secondary hyperthyroidism. Patient is in full-blown hyperthyroidism. How will you treat this patient? Hello?
Sir, under anti-thyroid cover, patient will be planned for surgery, sir.
No, that's not the right answer. It's not under antithyroid cover. The patient has to be brought down. If the plan for surgery, such a large thyroid gland, it is indicated for surgery. Surgery is indicated. But before surgery, the patient has to be brought down to euthyroid status. Okay, that's the right answer. It is not under cover of antibiotics, under cover of antithyroid drugs. It is not like antibiotics. It is not under cover of antithyroid drugs. So I will bring the patient to you. My treatment would be surgery. What surgery you will tell later. My treatment would be I will offer surgery after preparing the patient for surgery. Preparation of this patient would be to prepare a thyroid gland by bringing down the patient to euthyroid status. Understood?
Yes, sir.
Yeah. So how will you bring the patient? Why do you have to bring the patient down to euthyroid? Why not operate straight away? Yes.
The thyroid storm, the risk of thyroid storm.
What is that thyroid storm? How does that happen?
Sir, because of the increase in the thyroid hormones, the biochemical and physiological manifestation of thyroid hormones should be under control. Otherwise, patient will land up in thyroid storm. If it is in unprepared thyroid gland, will perform surgery.
It happens after surgery or during surgery.
Sir, it can happen during and after surgery also, sir.
Yes. Why does it happen? What accentuates it?
Because of excessive release of thyroid hormones from thyroid gland, sir.
Why does
Because
it? Why,
patient
if you're
is already
while surgery, why does it suddenly thyroid toxin get related? So the answer would be during surgery, we will be manipulating with the thyroid gland, tugging here, tugging there, squeezing, holding. At that time, enormous amount of thyroxine can be released into the blood in an unprepared patient. So that enormous increase in thyroxine level lead to the accentuated symptoms of an already existing uncontrolled hyperthyroidism. Patient will have everything which is high, tachycardia, hypertension, sweating, dehydration, palpitation, everything will happen. So that is a thyroid crisis, which is difficult to manage. And therefore, in order to avoid this thyroid crisis, thyroid storm, you have to bring down the patient to euthyroid and only then touch the patient. I'm not going into the other aspect where you can give propranolol and treat the patient. That's a different matter. That is only for theory, not in practical purposes. So how much tablet you'll give, how long you will give, and what will you tell the patients when you start these medications? Please.
So initially the patient is started on 30 mg of carbimazole, TID, and then later it is
30 milligrams TID. That's too much.
sir, 10 milligrams TID, sir.
Yes, 10 milligrams 3 times a day by the clock. Yes. And the patient is asking, will I become all right tomorrow?
No,
Sir,
sir.
it will take more than 8 days, sir, because the thyroid hormone half-life is also already more than 8 days. So it will take some time to act.
Yeah, it has to be washed out. And then only it will start acting. And how long does it take for the patient to become euthyroid? The patient is asking you.
Around 6 months to 2 years, more than
No.
6 months.
No, the standard treatment is 6 to 8 weeks, the patient will become euthyroid. After that, she is ready for surgery. Previously, we used to give lugolzidine to bring down the vascularity, to make the gland firm, but slowly that practice has been given up by most of the surgeons. And then you subject the patient to surgery. Is that clear?
Yes, sir.
Yeah. So, right, this patient has been done, pre-anesthetic checkup has been done. Let's go to the OT, please. Dr. Sampathan is there? So can we proceed, sir? We have time. Yeah, it means we can proceed. We can proceed, sir. Okay, go ahead. Patient is fit for surgery. What will you do? What you want to do?
So we can do a total thyroidectomy for the patient.
So your plan will be total thyroidectomy. Yes, please proceed. Let's go to the OT table and please tell us what you will do every step. It was correct exam. Yes.
Sudarshan sir, there are some unanswered questions in the chat box.
Oh.
Chat box.
Sir, yes, it is not necessary, but you can, this thyroid is something like a hernia. There's a lot of signs and questions that can be asked. It's a coccus sign need not be. It should not be done also, I suppose. And one thrill can be palpated throughout the gland, yes, but initially it will be felt in the superior pulse. There is a reason also which has been told. And when there's a thrill, invariably you can auscultate in the upper pole. If it is present, the bruit can be heard. Third one, if the anesthetist inserts a Rice tube during crisis. Yeah, anybody else can answer this? I have not come across this incidents.
Extended.
Yeah, please repeat.
The neck is hyperextended, and there is a sandbag placed between the shoulder blades to allow for the adequate hyperextension and to make the thyroid gland more prominent.
Anything else in the position?
His head is supported with the help of head ring, sir.
That's okay. That is to stabilize. The patient has to be in a 15 degrees head and tilt, head and up,
Yes,
so that the congestion in the neck is reduced. These are standard things that you will observe. Yes. Then what will you do? What about the incision?
So A coccus incision is taken 2 centimeters above the suprasternal notch.
Okay. After making a mark, that's a traditional thing. Yes.
After the incision, the skin and the platysmal flaps are raised up superiorly up to the thyroid cartilage and inferiorly up to the suprasternal notch.
Yes.
Then a vertical incision is made on the
What vessels do you come across while raising these flaps?
anterior jugular veins.
Okay. Yes. Next. Yes, you have raised the flaps very nicely.
And in the midline, we have to give an incision to divide the muscles and divide the strap muscles to access the thyroid gland.
What is the structure that you see after raising the flaps? The white structure. After raising the flaps, you see some white structure.
Deep cervical fascia, sir.
Yeah. So one question is, why in the skin you make a horizontal incision, and in the deep fascia you make a vertical incision?
Correct.
It's along the Langus and line, we have to make a curvilinear incision while taking skin incision for the cosmetic appearances.
Yeah, it's a skin crease cosmetic incision. Yes. Okay. Why in the deep fascia vertical incision? Why not follow the same incision? No.
Along the line of strap muscle fibers.
No. You would have seen that all the vessels run vertically in the neck. So you don't want to be injuring them. That is why. And then you'll be dividing the strap muscles also. So you don't need to do that. That's why you take a vertical incision and reflect the strap muscles. Previously, most often surgeons used to do a division of the strap muscles also, but now there's no need. The techniques have changed. No need. So you open the deep fascia, and then along with the strap muscles, you reflect them laterally. Yes. Next, what do you do? What are the strap muscles? Please name the strap muscles. Can you?
Sternohyoid and sternothyroid, sir.
Yes. Then does the omohyoid come there?
Yes, sir.
Yes. So where do you divide them if you're going to divide them in large thyroid glands?
Sir, in the upper part of the strap.
Good, good. So why not lower aspect?
Sir, because of the ansa cervicalis supplying the lower part of the strap.
No, no, not supplying the lower part. The nerve supply comes from the lower part.
Yes, sir.
Anyway, the strap muscle don't have any action, no, so it is told. So why do you worry about it at all? If the examiner asks you such a question, you keep quiet. Okay.
Yes.
Right. And then reflecting the strap muscle, what do you do next?
So after reflecting the strap muscles, we get access to the thyroid gland. We have to dissect to find the superior pole of the thyroid gland.
Before superior pole, is there any other vessel which is described, which you should go to first?
So in middle thyroid vein is there in 40%
Yes,
of the
yes. Many surgeons may not come across it, but it is a constant finding usually. You have to ligate the middle thyroid vein. Why do you have to take such care of the middle thyroid vein? What's the reason? Where's can you answer yes or no? Not sure, you must tell I'm not sure.
Not sure.
Okay, the middle thyroid vein is a short and flimsy thyroid vein, which drains from the side of the thyroid gland directly into the internal jugular vein. So during mobilization, this may unnecessarily tear and bleed. Sometimes it tears like a sugarcane. So that lead to enormous bleeding. That is why you have to ligate the middle thyroid vein. And then once you ligate the middle thyroid, it is easier to reflect the thyroid gland medially so that you get hold of the superior pedicle, which you will go first. Right. Okay. So you will ligate the superior pedicle.
Yes.
How do you ligate it? Standard procedures.
Close to the gland, we have to ligate the superior pedicle.
And you have to make a doubly ligate it. Okay.
Yes.
And then what do you do with the inferior pedicle?
So, after identifying the recurrent laryngeal nerve, the capsular branches are ligated.
Yes. Previously, it was thought that your upper pedicle, you could ligate close to the thyroid gland and lower pedicle away from thyroid gland in continuity. No. You have to search for the nerve, recurrent laryngeal nerve. It is always there. It's not very difficult. And then you identify the inferior thyroid artery. It is again seen constant, either running in front, behind, or the nerve may be running in between the branches. We have seen all that, and you also have seen. Then follow the branch which is going to the thyroid gland individually like that, and sparing the parathyroid. Okay. So having done that,
Yes.
what about the inferior thyroid veins? Is it a single vein or multiple veins? Superior pedicle was simple, no?
Yes, sir.
Inferior pedicle, the veins run in a leash. So you'll have to either use a bipolar or ligate them, taking care that you trace the recurrent laryngeal nerve. While tracing the recurrent laryngeal nerve, don't be so enthusiastic to demonstrate the nerve denuding its blood supply. Vasa nervosum. Just identify and leave it there. Okay, so total thyroidectomy, you do a similar procedure on the opposite side. What are the other surgeries that you do? For example, in thyroid, what are the other surgeries? Standard you can accept. Dog is barking, not my house. What are the other standard surgeries which are described? Unacceptable. For a salty nodule, what will you do?
Hemithyroidectomy.
Yes. You can do total thyroidectomy to all the thyroid cases. That's a current concept. But if you're asked what is hemithyroidectomy, you must be able to tell what is a standard hemithyroidectomy. What is standard hemithyroidectomy? What is the structure that you remove?
Involved lobe, lobectomy plus systemectomy plus removal of pyramidal lobe.
Better answer? You will remove the involved lobe, isthmus, and a cuff of tissue from the opposite lobe, because it is said that it's the isthmo-lobular junction where the nodules develop. That is a standard. Now we are doing total thyroidectomy for every other case, which is acceptable. Right. What is the other operation? Total thyroidectomy and then hemithyroidectomy. Anything else standard you can tell?
Near total thyroidectomy.
What is this near total thyroidectomy, please?
So, a sleeve of the thyroid tissue is left in the tracheoesophageal group, and the rest of the gland is removed.
What is the idea behind this subtotal thyroidectomy?
So,
What is the idea?
so to avoid RLN injury.
How much tissue you leave behind? What's the idea?
Size of the thumb, so that the patient need not take.
Okay, thumb criminal you won't get. You must leave enough thyroid tissue. One is for the normal functioning of the gland.
Yes.
That is the standard. And how much thyroid to leave behind so that the patient does not have recurrence one. And the other one is patient has enough secretion is a sleeve of thyroid tissue in the case of a group so that you may protect the parathyroid gland and recurrent laryngeal nerve. So other descriptions are with the UG can tell is the size of the left thumb of a patient. At that time where you will get the patient thumb and all, or something like 4 to 8 grams at each pole, which equals the normal weight of a thyroid gland is about 25 grams. So you can leave enough tissue. So that's why they say 8 grams or 4 grams. And then that will also give supply to the parathyroids. This is the reason why they were doing subtotal thyroidectomy. But now with the current concept where recurrent laryngeal nerve, parathyroids all can be preserved and anatomy is so well described, you can get away doing a subtotal thyroidectomy or a total thyroidectomy. Okay. Any questions, sir, from the audience? Any?
So good evening, Dr. Himagirisha from St. John's.
Yes, sir. To me or to
Very
you?
good evening. Very nice way of narration, sir. You took the narration very well along with the PG. A few points, if you can permit me.
Yes, sir.
Am I audible?
Please, yeah, you can add, sir. Yes.
Yes, sir. So yeah, sometimes in a big thyroid, we actually once we raise the flaps, we retract the sternomastoid, especially when the lobe is when the nodule is laterally placed. So when we retract the sternomastoid, we divide the fascia between the sternomastoid and the strap muscles. So that way we are freeing the lateral surface of the gland. That will actually help us in medial rotation of the gland while performing the surgery. And then with regards to this division of strap muscles, Again, as you said, it is facultative. We can choose whether to divide or not. But as you rightly said, if the lobe is quite big, then there's no substitute to proper exposure, especially of the upper lobe. And if that means that we have to divide the strap muscles, so be it. We divide the strap muscles and then dissect in the upper lobe. When we are actually dissecting the upper pole, we try and make an effort to look at the external branch of the superior laryngeal nerve.
Yes.
So this is a nerve that starts off lateral to the superior thyroid artery, and then it crosses the superior thyroid artery and comes to lie in the, the groove between the upper pole of the lobe and the cricothyroid muscle. So we call it the reeve space. So the attempt is made to actually see the nerve and preserve the nerve. And because this crosses the pole, the closer we tie to the pole, the better. So we actually get on the pole. And this middle thyroid vein, sometimes we identify, sometimes we don't. And in the course of the capsular dissection, the middle thyroid vein, sometimes it's very small, it kind of gets ligated as such. So earlier we were being taught that it is a must to seek out the middle thyroid vein and ligate it before we proceed further. We kind of found that it's not that essential as long as we take care of hemostasis as we go through the surgery. And capsular dissection is another thing that is being stressed upon. So we dissect on the capsule.
Yes, sir. Proceed. Hello. I think your audio dropped, sir. Hello, can you hear me? Dr. Himesh Rao? Hello, can you all hear me?
Yes, sir.
I think Dr. Hemigrish's voice dropped, I think, call dropped. Can you all hear him?
No, sir.
Okay.
Yeah, I think it got, my thing got muted actually. Can you hear me now?
Yes,
Yeah,
sir.
now, yes, we are able to hear.
Yeah,
Go ahead, sir. Very good.
Yeah, please go ahead, sir. You were telling me something.
Yeah, correct. This middle thyroid vein, it is true. It is true. Many of the times you don't even come across it, but when you come across it, just to demonstrate this thyroid surgery, I think that's one of the fine surgery where you can demonstrate structures and that beautiful anatomy created by God.
Yes, sir. Agreed. Yes.
Interesting, like parotid gland and what should I say? Parotid gland also. It's more of dissection of other thing than the thyroid.
Yes.
Than the gland itself.
Yes. The whole anatomy in the neck, it's actually quite liberating. Actually, it's quite nice to be able to look at the structures and especially for somebody who is a student of anatomy, it's quite a rewarding experience.
Yes, sir.
And for all practical purposes, we don't discuss even subtotal thyroidectomy. So nowadays, I don't know. I don't think it's even necessary to discuss.
Yeah. So what happens is the students, they are going for exam. So suppose the standard teaching should be that they should know all these things. And when they do not, some examiner asks, either a senior or a youngster asks, what is subtotal? And if they sit there without knowing what it is, they get tense.
With all due respect, I think we should stop penalizing the students for not knowing subtotal thyroidectomy. So this is my humble opinion.
They will not. But definitely the assessment improves.
Yeah.
Like we did not talk about Dunel's. So you don't know what comes up.
Exactly. Yeah.
It should be broad-based general surgery.
Yeah.
Thank you, sir. Thank you.
Anyway, thanks for letting me speak, sir. Very nice case.
Sure, sir. Very nice, sir. Right.
Thank you.
Regards to all in St. John's. I know, Dr.
Sure, sir. Certainly. Yeah.
Nice, sir.
I look forward to meet you soon.
Sure, sir. Also.
Right.
Nice, sir. Thank you, sir, for interacting and adding up.
My pleasure. Thank you.
So, I think we'll end the session with this. Any questions? Any other further?
Sir, one comment, sir.
Sir, please.
I'm Dr. Sunil, sir, BMC.
Oh. Good evening, sir.
Nice. Good evening, sir. Nice case presentation and discussion, sir.
Thank you, sir.
I just wanted to add
Yes,
our SSB secretary, Dr. Prem Kumar's classification of neck triangles are there, which are in relation to thyroid.
Please.
So Fortunately, he is also online.
Oh,
I just wanted to put it across the SSP so that we have people like Dr. Prem who are
yeah.
this
I thought Dr. Prem
particular
was-
classification is also taken in Dr. C.S. Rajan's recent book published.
Okay, sir. Okay,
Thank you,
okay.
thank you, Dr. Sunil. Thank you, sir. Actually, it is published even in the World Journal of Endocrine Surgery.
Excellent, sir.
The triangles of the neck, I even proposed, combined all the triangles of the neck and made it into an area of danger so that it's easy for the surgeon to identify the structures.
Yeah, yeah.
It was
Very nice, sir. Very nice, Dr. Premkar. I also know that you are one of the, can I use the word pioneers in doing laparoscopic thyroid
Thank
surgery?
you, sir. Anyway, it was a good adventure. Plus, I have even one study which is for identifying the frequency of middle thyroid vein, which is also published in the World Journal of Endocrine Surgery.
Okay.
As you can see, the frequency of getting the middle thyroid vein is very less, even though it is described as one of the main reasons for bleeding.
Yeah,
But
yeah.
not much we encounter of the classic description of the middle thyroid vein.
Yes, yes. My experience of middle thyroid vein is frightening. When I was in my younger days, so I was doing a thyroidectomy, must be a hemithyroidectomy or something with a house surgeon. PGs were not there with a house surgeon. So very nicely, as my boss taught me, my guru is Dr. Dinesh Babu, may his soul rest in peace. So he was a wonderful person for me. So I learned it from him. So middle thyroid vein, very judicially, I had dissected just like my boss did. And there we now used to use cautery. So we used to use those mosquitoes on one side and the other side, ligate and divide. So as I ligated and divided, I think I got distracted by somebody on my right side. So the house surgeon, I said, okay, I remove the artery. He removed the artery. And then all that I heard him say is, sir, what I saw? He had torn off the middle thyroid vein from the jugular vein.
Oh my God.
Like sugarcane, and it is welling. I'm still a youngster. I don't know what the hell to do. Immediately, again, my gurus put a big mop. First prayed God, what the hell this fellow? I look at this fellow, I'm scared he's going to faint. Because he knew something very horribly he has done wrong. He was going to faint. Then I had to manage him. Then what I did was I put my thumb at the base of the skull and close it. I had worked in CM's well in renal transplant, so I knew how to close the vein. So I took a fine suture and closed the internal jugular. That's the fright of internal jugular vein. And bleeding.
I agree with you and maybe probably with Dr. Himagrishi Rao also, because students need to be aware on what subtotal is, what they need not practice it, or maybe it's absolute or no discussion. But as you rightly said, so there are some examiners who still ask such questions. They need to be aware. Maybe they need to be aware that we don't do much also.
Yeah, they have to go step by step.
We don't do that, but they need to be aware what exactly it means and whatever, little bit.
Exactly, sir. Yeah.
I agree that it should be discussed, but they should even know that we don't do that. But let us not try to avoid that topic, I think. So. Thank you, sir. Nice discussion.
Thank you, Dr. Prem Kumar.
We go to the next case, sir, or we have a second case.
Yeah, one case I think we have brought in this time now.
One case.
I thought one case in nice detail. This is a common one coming for postgraduates.
Okay, sir.
Yeah, and
thank you, Rajan, sir. You made a mention in your book. It's a big prestigious thing in your book, actually. And I recommend all the students to please buy that book and go through that book. One of the best books, actually, which Rajan sir has written, and every page is amazing, sir. Good evening, sir. Every page is amazing, sir. It's a wonderful book. Every day I try to get something interesting from there and try to tell my students.
Even if you don't get anything interesting, remember the joke on that page, sir. You will become very popular.
yes, Sergeant sir. Good evening. Hi.
Good evening, sir. Good evening, Sudarshan sir. Very, very nicely taken clinic. I've been listening quietly.
Oh, you were there, sir. Yeah.
I didn't want.
All COVID things have taken away some of our teaching sessions also, sir. Really.
Yeah. And COVID has made you look much more gray, sir. What is this?
Sudarshan sir's anatomy is Grace anatomy, sir. And sir did almost all the talking. He was non-stop. Fantastic, sir. Sudarshan sir.
Well done, sir. Well done. Nice, nice.
Thank
I
you.
wish more students go and attend your clinic, sir. You're very, very correctly at the level of the student you're taking it. That is very important.
Yes, sir. Yeah. And it should be useful also, sir, in their practical
Yeah.
aspects.
Yeah. Yes, sir. Yeah.